Hello everyone, today we'll speak about systemic scleroderma in children, which is also known as juvenile scleroderma. So, it's a systemic disease. It's autoimmune connective tissue disorder characterized by vascular dysfunction, immune dysregulation, and fibrosis, which is excessive collagen deposition in the skin, and internal organs as well. Yes, in the children, it's known as juvenile systemic sclerosis. Systemic because it will cause some problems in a lot of what do you call it? In a lot of systems, not just a single system. So for the epidemiology, it's a rare disease. It's about 1 to 3 per million children, and it's more common in females more than males. The clinical prevalence. It's a multi-system disorder that can cause significant morbidity. Early recognition and good management are crucial to improve the outcomes. So for the pathogenesis, we'll have autoimmune activation that will get triggered by abnormal immune response, possibly related to genetic or environmental factors. We will have a vascular injury, endothelial damage lead to a dysfunction in the blood vessels that will lead to ischemia, and this we will see it very good in Raynaud syndrome. Fibroblast activation and collagen overproduction. Immune mediators will stimulate the fibroblast, which will get activated, and we will have an excessive collagen production that will lead to fibrosis. Molecular mechanisms involved of cytokines. We'll have cytokines that get released and growth factors that will perpetuate inflammation and fibrosis. And we'll have autoantibodies such as anti-topoisomerase, which is also known as SCL70. We'll speak about it later. For the clinical features, the skin and vascular involvement first. For the skin changes, we have progressive thickening and deterioration of the skin. Actually, in real patient, the skin will get so hard, it's even very hard to put a cannula in it, because it's honestly, it's like a scale, or it's like an Iron Man or something. The skin is very strong when you touch it. It's very feelable. I hope you all saw patients with scleroderma and touched the skin to know what I'm talking about. So it will start with the hands and may extend proximally, may present with a shiny tight appearance and reduced range of motion. If there's no elasticity in the skin, you can't do the elasticity test of the skin. For the vascular signs, we'll see Raynaud phenomena, which is we will have episodic digital color changes, white to blue to red. This is because, as we mentioned, that we will have I mentioned somewhere here, we will have dysfunction in the blood vessels. Undefault capillary changes, we will have abnormal capillary pattern observed on the capillaroscopy. Additional skin finding, we have telangiectasia, which is a small dilated blood vessels. When we press it, the blood will disappear. When we remove our fingers, the blood will come back. Unlike adults, calcium deposits is less common in the children. So this is two kids with scleroderma. As we can see, actually from the looks we can identify the patient. So first of all, the tip of the nose is very special in the scleroderma patients. As we can see, it's pointy. This is the first thing. As for general information, this we are talking about kids, but if we have an old patient, he will have wrinkles on all the face except around the mouth. Also in the patients with scleroderma, they will have thin lips. This is also a thing, and we can see that their skin is tight and shiny. This is Raynaud syndrome. We will have skin turns to white, then purple because the blood vessels will react, and then red because the blood flow will return. As we can see, white, purple, red, Raynaud syndrome. This is telangiectasia. As we can see, it's dilated blood vessels. Clinical features, internal organ involvement. For the musculoskeletal system, we have joint stiffness, contractures, and pain due to the skin tightening. Gastrointestinal, we will have esophageal dysmotility causing a reflux and dysphagia. Gastrointestinal hypomotility may lead to nutritional challenges. Pulmonary will have interstitial lung disease can develop leading to a shortness of breath. Risk of pulmonary arterial hypertension is also present. For the cardiac, myocardial fibrosis, arrhythmias and conducting abnormalities may occur. Renal is rare, but we can have renal crisis. It's more common in adults. For the diagnostic, we will do first of all clinical diagnosis based on history, physical examination, and characteristics of the skin involvement. And we have a criteria for this. We will see it later. For the lab test, it's very important to look for the autoantibodies. We will see the SCL70. It should be positive, maybe positive. Other antibodies like anti-centromere. It's typical for limited cutaneous scleroderma. It's less common in juvenile, but it also could be positive. And ASR and CRP may be elevated. This is the the criteria. So we need a score of 9 or more, and we will identify the scleroderma diagnosis, as we can see. This is the things. Also, we can see digital tip ulcers, to be honest. Puffy fingers, pitting scars, all this, and this is the labs. Diagnosis. Now for imaging and functional tests. For the echo, it's just to evaluate the pulmonary arterial hypertension or cardiac involvement. CT for assessment for the interstitial lung disease, and a pulmonary function test to monitor the lung. Skin biopsy may confirm the diagnosis by we will see there's an increase in the collagen deposition. It's not always necessary. For the treatment, so no cure exists for this disease, so we'll do a symptomatic and multidisciplinary approach for the treatment because it's systemic. So we'll need rheumatology, pulmonary, cardiology, and physical therapy. So, and we will use immunosuppressive therapy, because it's autoimmune disease. We'll go with methotrexate, which is a DMARD, or one of those, cyclophosphamide, or mycophenolate mofetil. The dosages are here, you can read them. Then we will go to vasoactive agent and symptomatic management. Calcium channel blocker to manage Raynaud phenomena. It will help with the blood supply, or PPIs for GERD. And physical therapy will be good, and nutritional support as well. The complications, as we mentioned, we can have cardiopulmonary complications like interstitial lung disease or pulmonary arterial hypertension, arrhythmias, or myocardial fibrosis, because we will have increased collagen deposition. Musculoskeletal complications, we will have some problem with the joints. We mentioned that already. GIT, we will have reflux, dysphagia, malabsorption. Renal is rare in children. That's actually everything for today. I hope you liked the lecture, you found it useful. Thank you so much for watching. Have a great day. Goodbye.